Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes it's professional, sometimes it's personal. Today, my guest is Laleh Gharahbaghian. I think I pronounced that correctly. I hope they're close. Who is with Cerebell, but we're going to be talking about um, um, status epilepticus, but most importantly, the kind that you don't see and what can be done. And actually, to be perfectly honest, I'm such an old dog. This is a pretty new. I know it's not new to young docs, but it was kind of an interesting read for me for what we put in the Emergency Physicians Monthly, and so I wanted to bring you on and talk about Cerebell and point of care testing. But at the same time, since this is your area of expertise, I want to talk more about actually um, status epilepticus. And okay, so, but before we get to that, I want to talk a little bit about you. You were tell me about where you came from, your education. You're obviously, we talked before we went on the air that you're from California. So bring me up to speed on that. You're a Stanfordite, is that right?
That's right. I grew up in San Diego, so sun and surf is in my heart and soul.
Hmm.
And I went and got trained in emergency medicine at UC Irvine,
Okay,
where point of care ultrasound was
right.
quite advanced under Dr. Chris Fox, who is my friend and mentor and continues to be.
Okay.
And I realized the impact of new technology, especially the emergency physician's role in point of care
Hmm.
capabilities.
Yeah.
And I stayed there for ultrasound fellowship. And then I was lucky enough to get a job at Stanford Emergency Department to, with Dr. Sarah Williams, to help direct the point of care ultrasound program in the emergency department, and have remained faculty ever since, where I then began to do a lot of quality work, case review. I now chair the case review committee. I was the quality director and medical director up until just recently, and now I'm the director of process improvement there.
Wow. Very few people I know of come straight out of the residency training and then stay at the same place forever. So that's really that's great. Of course, you're still relatively young, so we'll see if your entire career is like that. But at the same,
Thank you
that's
for saying that.
and but let's talk about Cerebell. Okay, some of our readers, our viewers, may be familiar with Cerebell, but I want to set the stage. In January last month, we did a piece by you. We published a piece by you, non-convulsive seizures, and it was quite interesting. And I want to start with an explanation when you to bring us up to speed on non-convulsive seizures and their importance, especially in various situations that you wouldn't necessarily think of seizures. I'm looking at, I'm going to just let you run for just a second and talk about non-convulsive seizures.
Sure. So I have to say, it has nothing to do with age. It's still a clinical conundrum, even to those who just recently graduated. Non-convulsive status epilepticus basically is an electrical storm of brain activity where there is no shaking, there's no convulsions, it is not obvious, it is clinically inapparent. The most common sign and symptoms involve some degree of altered mental status. People will come in of all ages depending on what their medical history or medical reason for being in the emergency department is, with
Mm-hmm.
some sort of altered mental status. And there are clinical scenarios where there is a high risk that non-convulsive status epilepticus might be the etiology. Most
Well,
commonly,
yeah,
that
before we get into that, I want
sure,
when you say it's not obvious, a mental status change. Drill down on that just a little bit. Are you talking about
sure.
confusion, coma? How severe would you need to see the mental status change in order for you to be concerned that there is non-convulsive seizures going on?
That's what's worrisome is that it could be all along that spectrum.
Okay.
We've
Okay.
actually seen it with mild confusion. Sometimes people who just speak a bit differently than what how you would otherwise communicate with them, and you don't know, is that how they normally speak or not?
Wow.
Or people coming in just floridly unresponsive and in coma state. So all of that and everything in between could be non-convulsive status epilepticus in the high-risk altered mental state.
And before we get into the various things that could present that way, tell me what happens if you miss it? As I suspect I've done many times. I'm sitting here kind of scared, thinking, how many times have I missed this?
And I'm sorry to say I've missed it myself before we had Cerebell, and it's those cases that really weigh on us, because once we finally get an EEG that is 1 or 2 days later, then it's too late for a variety of reasons. Of course, time is brain.
Okay.
The similar effects that a convulsive status epilepticus untreated for so long is the same thing that happens when it's non-convulsive status epilepticus. It's still an electrical storm. You will have cognitive deficits in patients for months later, with increasing percentage of time that occurs depending on the number of hours later that is diagnosed and finally treated. The reason why the emergency department is so key is that the percent of time that is needed in order for first-line treatment to become effective against non-convulsive status actually drops to 50% if it's 2 hours into the non-convulsive status epilepticus state, and continues to decline after that. And that's why, as an emergency physician, understanding that literature and reading up on it quite a bit, doing our own study and research on it, and then seeing the clinical case scenarios in the position that I had with Stanford, that it was obvious to me that we have a role and that the patient can suffer if we don't do our part.
Let me look at I'm looking at the list of conditions that can coexist with high risk, non-convulsive seizures coexisting with high-risk conditions. And the one, obviously you said following convulsive status epilepticus, about half the time the convulsive phase goes away and the patient is still having a brain seizure. That's pretty frightening. 32% of the time, sepsis is associated with it. Brain tumors, 20 to 40% of the time. That's pretty traumatic brain injury. Okay, we've just been working with Abbott talking about brain, biomarkers, looking at traumatic brain injury, and how many times are we missing someone has a traumatic brain injury that then goes into non-convulsive seizures? Obviously, in recent neurosurgical procedures, subarachnoid hemorrhage, 20% of the time. Here's one that we see. Cardiac arrest with ROSC, 10 to 30% of the time. When they're resuscitated, they are developing non-convulsive seizure activity. This is, I don't know about you, but this is kind of worrisome to me, to see those kinds of numbers.
It's surprising, isn't it? I was shocked when I read the literature, which really only started in the 1990s to really ramp up, to understand it better, because it was going undiagnosed for so long until, of course, it was too late. Yeah. And when you see those percentages come out, and knowing what the impact is when you don't treat it in a timely fashion, then it's worrisome. It's something we have to care about, and thankfully there's something we can do about it.
Go back a little bit. Do you know, when was this first kind of started to be recognized? When people started looking and saying, geez, 2 days later, this guy is in status. And you think, well, when did this start? Well, maybe he's been in status the whole time. When did this become, help me out here. I mean, is this something that has been recent, or is this something we've known for a long time? What's the story with that? I know Cerebell, we'll get to Cerebell in a second about point of care testing and being able to to diagnose it, and the advantages it has over an EEG, calling a neurology lab and getting an EEG, which we all know is virtually impossible, or at least in a timely manner. But what's the historical sequence for this coming to the fore? Just in the last year or two?
No, actually, it's been around for quite some time. I think that it was initially appreciated in theory probably about 40 or so years ago.
Oh my
And
gosh.
much of that comes kind of within the advent of EEG technology as well, and the
Right.
ability to monitor and understanding quite late why a patient is continued to have poor responsiveness or an altered mental state. And they found that the patient, although not convulsing, was in status epilepticus. And so then more studies started, and the ramp up really was in the 1980s and 90s
Okay.
when there was better detection, better ability to study it,
Hmm.
to see how often is this occurring. And then, of course, in just the last 5 to 10 years is when organizations like Neurocritical Care Society and the American Heart Association started to pay attention to this, especially in their patient population of their expertise,
Hmm.
and started developing that EEG and timely EEG be part of their guidelines for convulsive status epilepticus and also for post-ROSC cardiac arrest.
Yeah, I would imagine that this is one of those situations where there is a chasm of quality between the community hospital and the academic center, because I would suspect that at the community hospital, this is just not much on their radar. And am I wrong there? I mean, I've been in community hospitals for a long time, and frankly, I don't hear people talking about this.
I think there's still so much more to come. I think we adopted devices to be able to understand it and detect it early. I think
Hmm.
Stanford is considered an early adopter right now, even on this date in February of 2022.
Wow.
And we just found out about it just a couple years ago. And so,
Wow.
of course, I can imagine not only community sites, but other academic centers too.
Wow. Well, okay. Now that we've put this fear of God in everybody, you're missing something that you shouldn't be missing, and it has devastating results when we do miss it. Okay. Old school way of approaching that was to call neurology and get them off the couch and ask them for an EEG, and they tell you next February we'll do the EEG. I don't know about it. I'm being facetious here, but I've never ever gotten a neurologist to respond in a very timely manner from the emergency department. More so now that, if you're a stroke center or something like that. But certainly, for the most part, the neurologist that I practice with don't want to be bothered from the emergency department. So getting an EEG, a routine EEG, is not going to happen in any kind of a timely manner. Enter this idea of point of care EEG and Cerebell. Tell me about that. Where'd that come from? Who figured that one out?
It was one of our neurologists.
He didn't
and,
want to
and
come in. That's what it was. He didn't want to come in.
it was one of our neurologists who, worked real hard and had a patient-centered focus on it, and asked several departments who, of course, have these high-risk patients come in, like our emergency department and others, in order to study its use case. And, over the time, what we found is that although the use of the neurologist still exists with non-convulsive status, because what Cerebell does is it's a very easy headband. Our tech puts it on, presses a button, notifies the physician to come to bedside. The physician has the opportunity to just listen also and hear whether seizure activity is there, and it's not hard to figure that out once you get the 5-minute online training in order to do that. And when you hear it, then you treat, and you don't wait, because if your suspicion is high and what is called the brain stethoscope shows and you hear seizures, you treat it right away, because again, that time to treatment is important, because again, it declines over time
Sure.
with the effect of that first line treatment. So you want to treat right away. If you're not confident, if you don't trust yourself, which can happen, we're human. If you don't trust that what you're hearing is a seizure because you don't have the experience yet, it's a new device, very typical point of care type of technology,
Right.
learning that happens, then there is actually an artificial intelligence procedure that is highly accurate that tells you within a few minutes, less than 5 minutes, the percent of seizure burden. And if it's over 90%, it's positive, you treat. And if it's anywhere between 10 to 90, if your clinical suspicion is high, then you can prepare to treat. You will call your neurologist, because then there's status epilepticus possibly going on because of your high clinical suspicion. However, if your clinical suspicion is low and you have what the machine calls a 10 to 90% seizure burden, then you call your neurologist to evaluate that and see. And if you have an epilepsy specialist there, even better, an EEG specialist, even better. Obviously, tertiary, quaternary academic centers have those readily available, less so with the community hospitals.
Yeah.
And even as important as that is, if your clinical suspicion is high, but your seizure burden is less than 10%, the patient's not having a seizure. They're not in non-convulsive status epilepticus. Don't treat it. And that's where we've seen actually quite a bit of change in practice, is where when our clinical suspicion is high, before Cerebell, we tended to treat. And we would sedate the patient, and then we think, boy, they're not getting any better. Let's intubate them and treat them more with sedating medications, anti-epileptics.
Yeah.
And come to find out, all of that was unnecessary for some of those populations. Yeah. And so whether it's negative or positive, it's clinically impactful to our practice.
Cool. Okay. That's now I'm jumping down. I'm actually looking at this. You mentioned the headband, and I'm looking at it right now, even though the viewer can't see it. And if you didn't happen to see Cerebell, the actual technology at the last ASAP or someplace like that, or maybe even see it at EP Monthly, I want you to describe it, if you would, what it looks like, what it's hooked up to. I mean, just describe the hardware for me, if you don't mind.
Sure. It's really just one headband, and it has various numbers on the outside of it such that the tech can appropriately place it from the forehead all the way to the back. Just one headband with a connect. There's one cord that connects it to the small device that you just press a button to start. It's as easy as that.
It looks so simple that when I saw it, I said, nah, this can't be for real. I mean, this is some gadget somebody came up with, and I have to say that I was impressed, so much so that I think that I can't believe it's not in every emergency department right now. I mean, honestly, I'm not getting any kind of a promotional deal with Cerebell, but this looks like something that should be everywhere. I mean, let's go back to this. Let's go back to this populate sepsis, tumors, suspected tumors, traumatic brain injury. Dang, how often are we seeing traumatic brain injury? I mean, we really need to, and somebody got their bell rung, and now we're saying we can pick up a biomarker, and say that your concussion is for sure, even though you didn't get I am such old school that I told people for years and years, if you didn't fracture your skull, don't have a bleed, we don't really have too much to worry about. That's wrong. That's absolutely wrong. And the idea of concussion, and certainly concussion that's not associated with a massive subdural or subarachnoid bleed, is a significant issue downstream. And here we have the other issue. This is a major advance. We have the idea that post-injury, you may have status epilepticus as much as 30% of the time. Wow. Wow.
And and I don't mean to use some of these case examples to scare anybody, but those are the obvious ones. I mean, we can understand how a traumatic brain injury or someone with post-convulsive seizures or someone with a brain tumor could have non-convulsive status. That makes sense to us.
Yeah.
Let me give you some examples of what I've heard both at our facility and a couple others. There was a patient who had a history of a traumatic brain injury on anti-epileptics, who also coincidentally had eosinophilic esophagitis, so had food impaction from chicken, as it always is, right?
Right.
And so came into an emergency department where GI was consulted to do an endoscopy to remove the
impact.
chicken.
Yeah.
So they got sedated uneventfully, wasn't waking up. But it was in the middle of the night. So they thought,
let them sleep.
Maybe they're asleep. It's 3 o'clock in the morning. And a couple more hours goes by. Patient looks like their blood pressure is pretty high, would respond yes or no to questions, but really unclear whether they were making sense. And then, of course, as emergency medicine, shifts change. A new physician comes in. They don't really know what the baseline of the patient was, right. even though there may be documentation. Is that how this patient with a history of traumatic brain injury normally responds, or how is this the case? They called the GI doctor to ask, of course, what is this baseline? And
what'd you
hours
do?
Go by,
what'd you do to him?
Hours go by. Then the morning physician says, let me do a full neurologic assessment here. Thought there was unilateral findings, activated a stroke code, the CT was negative. Finally, an EEG was ordered. This is prior to Cerebell. An EEG was ordered. About 6 to 8 hours later, it was placed. About 4 to 6 hours later, the results showed non-convulsive status.
Wow.
That patient was in non-convulsive status for nearly a day.
Yeah.
At least over the 12-hour mark, where the effective medications were tough, and it was a very tough job they had in order to control that non-convulsive status. Another patient, a young girl in her 20s, who was previously diagnosed with some sort of psychiatric behavioral disorder of some kind, because she would go in and out of these behavioral episodes that they thought she was acting out. So she was followed by a psychiatrist. She came into an emergency department where they thought, she's neurologically intact. She's not answering my questions appropriately. Although this is not like any psychiatric condition I've ever seen. But, we have this new device called Cerebell. Let's just put it on and see what we do, because I'll know in 2 minutes if it's positive or negative. And I get to practice listening to the device because it was new at the time.
Yeah.
Put it on, it was positive, greater than 90% seizure burden. The patient was in non-convulsive status, and neurology was on board. It turns out that psychiatric behavior was actually epilepsy from a part of the brain. And so the patient, who was a young female patient, got on appropriate medications and had been misdiagnosed for quite some time. So yes, those that you listed are the obvious ones, maybe not sepsis, but even the post-cardiac arrest, ROSC, is obvious, right? Because obviously there could be brain injury when there is any kind of low perfusion state or hypoxic state to the brain. So you want to do anything to preserve brain activity post-ROSC. But these situations, this is what we see in the emergency department, right? Patients come in with these past medical histories, doesn't make sense. We kind of do a CSI investigation as to what's going on. We have really wonderful clinical judgment if something is just not making sense to us.
Yeah.
And when you have this kind of device that you can rule out or rule in, it's great. It's great.
Do you know if anybody is looking at COVID-related neurological dysfunction with Cerebell? Has anybody slapped a Cerebell headband on somebody who's got fog or, you know, the more I think about this, the more I think that we probably should be looking at a lot of people, a lot, maybe everybody, but certainly a lot.
I don't know of any cases particularly related to COVID, but it's a great idea. I mean,
Right.
it makes sense, especially if there's anything that's kind of an off and on intermittent phenomenon where someone is not themselves.
Yeah.
And just to avoid a misdiagnosis or the wrong diagnosis.
Wow. Wow. You're definitely scaring the crap out of me.
You know, it's what I went through, and you know why. And again, I mentioned earlier my point of care ultrasound training and understanding just the impact of point of care devices. Not always do I feel that point of care devices that are developed, especially where I am in Silicon Valley, they're not
Yeah.
all practically relevant or as impactful as I'd hope that they would be.
Yeah.
There's very few that are. Point of care ultrasound was one of them, and this is the next because of the case scenarios that we see.
Yeah. You know, I really think that, you know, what we're talking about here is opening up emergency medicine to an area of opening up emergency physicians to recognition of an area that we've really not paid a lot of attention to. You know, when we haven't had the tools, to be perfectly honest. You know, like I said, my generation of docs, you know, if you didn't have a crack in your skull, you didn't have a bleed in your brain, there's not too much I could do about it. Go home, rest, you know, and it'll go away in time. That's not standard care now. I'm an old dog, and we definitely have some new tricks to do, and this is one of them. And I was really pleased to be a part of the rollout of Abbott's new point of care biomarker testing. And man, this is great. Looking at what Cerebell has to say. Looking at status, non-convulsive status epilepticus is an area that every emergency physician, we need to push this out. We need to push it out. So thank you. A lot of times I don't always get really educated by the podcast, but this one you've opened my eyes to an important area. So thank you very much.
Thank you for having me and for talking about such an important patient-centered, patient-focused topic that, you know, we go into emergency medicine for very good reason. And that is because we want to be able to treat anyone at any time, anywhere. That motto still stands true. And as medicine changes and new devices develop, it's exciting for us. We shouldn't be fearful of it, and we should try it out. And I would recommend everybody try out this device and see how it goes.
And for our viewers, I want to send you back to our website where Laleh talked about this. The article is called "Completing the ED Workup with Point of Care Brain Monitoring," January 19th of this year. And it's a great article, and even if it did come out in EP Monthly, I think it's it's really a timely piece of information that everybody should see. And in so doing, I want to push this point of care brain monitoring device called Cerebell, Cerebell, Cerebell. Look it up. If you're, I doubt, to be perfectly honest, if too many of our viewers have it in their emergency department right now, but it's something that you really, really should think about. And do the research yourself. Take a look at non-convulsive status and see how many times you think that you may have missed this, and what kind of improvement in care could happen with adding this to the point of care testing that can be done at the bedside. So thank you, Laleh, and thank you our readers and viewers for joining us today and joining us at EP Talk. Thanks.